And the first question, from your research, if a child has OSA at age 5, how many sleep studies can they expect to have by age 20? I've also asked, before I let you answer, I've also asked people, because we have 2 speakers, please to indicate to whom the questions should be directed. This is an undirected question, so I'll let you ladies fight over who should speak first, and then you can follow up. So let me repeat it. From your research, if a child has OSA at age 5, how many sleep studies can they expect to have by age 20? Who wants to go first?
I'll take that one. Pick one for the team, Fernanda. So I can't say an exact number from research. What I can say is it depends where you are within Canada. If you have access to a pediatric sleep specialist, if you have access to a pediatric in-lab sleep clinic. And for example, for Sainte-Justine, we were at 3 years, I would say, waiting list. We went down to 2 and we might go up to 3. We're losing a few sleep docs. So I would say the best, in an ideal world, we would be able to follow them up from 5 until they're 20, maybe, and continue to see them anyways clinically and to see their symptoms before we decide if they actually need a sleep study. But there's no great answer for that one, and no specific numbers.
Okay. Dr.
Yeah,
Almeida?
and I'll just add to that too. You know, it's not always really crucial to have those studies. So you have to look at what is the child's issues. Of course, if there is a treatment, there should be at least a baseline and a treatment. You need to understand, was that effective at all? And then with that, you would tend to recommend something only if the symptoms comes back, right? So you don't need to just keep looking and trying to find an excuse. Well, yes, my child is hyperactive, but you know what? He's 13. You know, many of us had kids. He's jumping everywhere. He's eating like a lion, and he's doing all sorts of crazy stuff. He's a teenager. Okay, so that's something to be expected. Don't think, oh, it's probably the apneas that came back. Well, no, you know, the child may be completely healthy and we can move on that. But for sure, you know, if the child is going through treatment, I would say it's very important to find a way to properly follow them up.
Okay, thank you. Next question. Are appliances effective in kids, and if so, at what age? Who wants to start?
They are, to a certain extent, in some kids, and some are more effective than others in different kids. So most of the studies that were published are done in Italy, and so they did the expansions, for example, they did the expansions at a younger age than what we would do in orthodontics. They did them around 5, 6 years old, versus in ortho for a narrow jaw, they would do it closer to 10 for girls, 12 for boys, depending on their tenor stages, right? We need to do it before puberty and before the bone solidifies that palatal suture. It really will depend on the child and the symptoms and how severe he is, and if they're under any other sites of obstruction like hypertrophic tonsils, any not just the form, but also the function. But yes, it can be efficient. I would say that we should follow them up and see if it's sufficient enough, or if we need to do an adjunct therapy to something else to follow up. As Fernanda said, following up these kids as they grow is the most important thing also. But yes, in some kids, it does have a significant impact. But in others, we need something more.
Yeah, and I'd just like to add as well that in those kids, they're kids already with an orthodontic need. Yes. So we shouldn't do an expansion for a child without, you know, an intrinsic maxilla. So if the maxilla is really narrow and needs an expansion, then yes. If the maxilla is normal, don't do that, because you actually may be making it worse. It's like everything needs a balance. So now suddenly the maxilla is too wide for that tongue, and the tongue gets kind of not numb or, sloppy, whatever you want to say, but it gets lost in this big cavity and it actually makes worse. And there are studies with that as well. So it has to be done if there is the need. And yes, for those children, yes, would be very important. And again, that would be expansion and as well maxillary mandibular advancement. But again, for children with a retroposition mandible.
Okay, thank you. Next question. Is it true that night balance device costs about $900? The night balance device costs $900. Who would like to take that one?
I will. And yes, it is true. That's the cost. That's also if you want to get one of those pillows, it's actually another 450 Canadians. I'll say it comes with a lot of other things, and it is an amazing treatment, really well studied. It will show exactly percentage of the time of the night, and it has been developed to a way to create the minimum arousal because it will vibrate until the patient moves, and just that could cause arousals and fragmented sleep. So there's a lot of technique beyond just something that would buzz if you go on your back. So I would say, compared to a lot of the other treatments for sleep apnea, it's worth it. And it should be covered.
and don't get me started. Dr. Huynh, do you have anything to add to that? No? Okay. Next question. How many patients in the community have both appliance therapy and CPAP to treat OSA? How many patients basically are on both treatments?
I don't know. I don't have that number. I can say, from my practice, that's something that is happening more and more. It's happening more and more because of oral appliances side effects as bite changes. They might want to have the other one, but also because of traveling. So a lot of patients very happy on CPAP. They still come to me and get an appliance so they can do traveling and things like that. And once they learn, to be able to be going back and forth. So I do have a lot of patients. I don't know percentage wise. If I'm starting to think, probably in my practice, anything between 5 to 10% nowadays are already having both therapies.
Okay. Dr. Huynh? No?
No.
Okay. I'm trying to be equal opportunity guy here. Okay. Next question. How critical is pharyngometry in the diagnosis and treatment of sleep apnea? How critical is pharyngometry in the diagnosis and treatment of OSA?
Again, I'll say people who know me know I'm very opinionated. I'll say,
really? Oh my goodness.
Not at all. Just throw the pharyngometry in the garbage. No, I didn't say that. I'll say research have shown that it's not useful, neither the diagnosis or prediction of oral appliance therapy or success, or even for the diagnosis of sleep apnea.
Okay. Next question. Any suggestions for interrupted sleep patient patterns who have no apnea? It says here low AHI and high IFL. Any suggestions for interrupted sleep with people with low AHI?
Okay, so maybe what I'm thinking is this question is trying to address something like patients more of what you used to say, upper airway resistance, or patients, with a lot of more sleep disruptions than anything else. I would think those patients may very well do quite nicely on some medications, like they're putting on sleeping pills and other things like that. But that would be not a question for me. I think those patients I'll definitely refer them to a physician colleague like Dr. Balson here to try to do a pharmacotherapy for those patients rather than the appliance, unless the snoring is also an issue. But other than that, I'll probably just try to get the patient to sleep a little bit deeper and manage to sleep well. I don't think that would likely be a problem for the patient unless the patient is heavily symptomatic. If just that, if it shows in the sleep study, and I know a lot of the sleep studies are going to show how much of this decrease in the flow, and there's flow limitation and so on. I do not pay that much attention to it, except that it does fragment sleep. and the fragmentation could be improved by other means rather than us trying to do beyond that.
Okay.
And I don't know if Dr. Baltzan would like to touch on this, just putting him on the spot as well.
Well, he put you on the spot by making you.
Yeah.
Hey, Mark.
There's a patient preference, a big preference. A lot of patients don't want to take nightly sedatives for their low arousal threshold. They're concerned about long-term toxicity, memory loss, dependence, addiction. So that's a big issue. Although the researchers and the people who write manuscripts love it, on the ground, it's not always acceptable. There's a newer medication called Dayvigo is the trade name. It works on the leptin receptor system so that it's not part of the benzodiazepine or tranquilizer system and has distinct side effects, still has side effects, but it doesn't have that dependence issue. It's relatively new, can be stopped when it needs to be stopped. So this is an interesting drug that I find now maybe the best step for this kind of patient.
Okay, thanks, Mark. Next question. Now, unfortunately, the next few questions are a little bit touchy in terms of politics and lots of other things. This is from a colleague in the same province I live in, which is Ontario, sometimes referred to as the black hole of healthcare. Ontario mandates a reason to take a cone beam, CBCT. What would the reason be for sleep when I refer a patient for cone beam? In other words, how does this dentist justify referring for cone beam when there's a concern about sleep apnea and or airway?
I'll say there's no justification at all, and you shouldn't be doing a CBCT. So they are really good and not allowing you to take one. Sorry.
Oh,
You
that's
asked.
okay. Yeah, don't apologize. Don't apologize. Next question directed to Dr. Almeida. And this looks like you've already answered it. In your opinion, Dr. Almeida, why would an ENT require a CAT scan but not look at a cone beam?
Okay, so these are my things with CBCT rather than CAT scan. That's why I think we've been kind of the garbage bin for medicine. The CBCT is an amazing in terms of being much lower radiation than the CAT scan, but really for us to differentiate any kind of soft tissue, it's useless. Okay, it's great for bone, amazing for implants. It's going to be for endodontics, really the state of the art in many ways. But really, it doesn't differentiate any soft tissue. So it's very hard for an ENT to properly assess really the problems or polyps or problems with the turbinates. Yes, we can kind of see the adenoids, but far worse than we for true CAT scan. Can we look at lingual tonsils? Can we look at a lot of other things that you can have much better clarity on a CAT scan than we can on a CBCT? So no, yes, CBCT is not for that. CBCT, yes, it will show you the bone and a deviated septum, but gosh, I can do that with an AP Ceph, and I can see that. I can, even on my pen, I can perfectly see, if I have the right technique, I can perfectly see that deviated septum. I don't need a CBCT. So why do the ENTs are looking beyond bone? They're looking at soft tissues, and not because they're looking for sleep apnea and if the airway is small or not, because many times, and we've shown, patient has this big of an airway and still have sleep apnea, they are awake, where some have this small of an airway and have no problems at all. So you cannot judge from those things. The function comes, as Dr. Huynh has said, function is so important. It's a lot more than the static image, and you need to know soft tissue. So yes, if I were an ENT, I would never look at CBCT either. I want the proper image.
Okay, Dr. Baltzan, do you have anything you want to add to that or stir up the pot a bit?
I look at a lot of CTs, but it's only the medical ones. I have seen some CBCTs. I understand that comment just from my own look. I haven't reviewed the literature. It's the bony structures that I can only see on the CBCT, and could never identify any soft tissues either. but I'm used to CTs where I can see the difference between lymph nodes, fat, and muscle, which you could never do with that kind of technology.
Okay, thank you. This looks like a good question to give to Dr. Huynh to start with. Addressing both of you ladies, can you comment on OSA in children and its association with ADHD? Dr. Huynh, want to start?
Yeah, I think there is some evidence.
Can we get you a little closer to your
Oh,
mic or
sorry.
speak up? Thank you.
Sorry, so I can speak on the side of dental sleep medicine. There are no current evidence that oral appliance, whether expansion or mandibular advancement, orthodontic mandibular advancement in kids, have an impact on ADHD. There have been some literature on TNA, adenotonsillectomy, but this might be a good topic for next year's speakers to get a specialist in this field. But regarding dental sleep medicine, there is just no evidence at all.
Okay, Dr. Almeida?
Yep, I think the same. Definitely with sleep apnea, again, there has been some studies looking and finding some kids who have been misdiagnosed with ADHD rather than having sleep apnea. Because again, what we see in children, they not always get sleepy, but any one of us who have small children know then when they get sleepy, they get hyperactive. And that's, you know, when they're throwing their tantrums before going to bed because they are overly tired, so they get hyperactive. So with that is definitely, there has been some studies showing that the prevalence of the children in the past diagnosed with ADHD have been misdiagnosed because they actually had sleep apnea. But I think as Dr. Huynh said, we never understood that well related now to anything related closer to us. But that's a very interesting topic. Again, for children, they tend to have hyperactivity a lot more than sleepiness many times.
Okay, thank you. This is directed to both you ladies. It's a compound question. I'll read it all and we may want to break it apart, but for clarity, I'll read you the whole thing first. Was there any attempt to correlate the presence or absence of scalloped tongues to OSA prevalence? Second part, does its presence correlate with more success when using appliance therapy or CPAP? Is the 70% association of scalloped tongues to OSA accurate in children? Do you want me to repeat that, or can you get a handle on that? Who wants to start?
So for our pediatric study, I can start with a pediatric study. It did not come out as being significant or having any type of risk factor associated with pediatric sleep apnea. I don't remember if we looked at it in our adult study.
What I can say, I did collect it for a while, and I was impressed how absent it was in terms of prevalence. You know, I always thought that would be really the major thing. But when we looked at scalloped tongue, it's not just a one mark here, or if I'm really looking for it. There are patients by all means with that, but I couldn't find it being any more prevalent than in a general dental clinic from my patients. So I don't feel it is an issue, but I don't think there has ever been a good study. And again, this is just me. I don't think we've ever published that data for adults. So that would be something interesting to do.
Okay, thank you, ladies. Paul, you're Dr. Paul Alter, who has a question for whom?
I guess it would be Dr. Almeida.
Okay.
Okay, so if you have a patient, I think he was about 20 years old, wakes up at night from pain, he's in pain during the day, goes to school. I do a sleep study on him, doesn't have sleep apnea. I did a CBCT on him. He's got a non-patent right turbinate and some pneumatization. And then when I look at I don't know if you'll be able to see that. So I'm looking at those joints and I'm seeing they're really superior and posterior. So that gave me some information that if he doesn't have sleep apnea, then maybe I've got to put these joints in a different position. And so while I agree that there isn't evidence direct to to not look at things that may have indirect applications seems like we, maybe there's something we could have tried, but we didn't try because and I always struggle with this. And I tend to sort of use whatever I have, whether it's direct or indirect. And oftentimes, like with this fellow, it worked. And in fact, his sleep really improved within 3 months. And then within a couple of weeks, he started having on and off pain again. And so I had him go forward and back and found that he had a click. So when I just redid his appliance, having not had the click, then he started sleeping all through the night, and that just went on and on and on, and he's been fine. And so it's showing me a lot of things that we just don't know about, like that a click can actually come about and do something about your sleep, or maybe it caused something else that interfered with the sleep. But the fact that not taking that CBCT, I would have never seen a joint like that, let alone its position. So I'm not asking to defend. I just wonder that the concept of direct evidence seems so strict that maybe it closes our mind to certain things that we're just not aware of yet.
Okay, so here you go. Have you also done a CBCT of their shoulder and knees? And if not, why not? So one of the things are...
Because I can't get a medical doctor to cooperate.
Exactly. But maybe because in medicine, they found that you could be taking images of all of those. And yes, patients have smaller joints, they have clicks, and they have all those things in multiple joints, but they do not need treatment if they're not expressed as being pain. The other thing that we know is that the placebo effect. Patients right now, and this one generation that we have right now, are having major issues, for example, with depression. And to have someone who cares about them and who's doing your best, which I'm sure you are, because you do care about your patients and you want the best for them, and you're trying to do something, and you're trying to change that tiny little bit every single night, that improves things. And that's when we looked at the placebo effect. And that's why research comes into evidence here, that we know that, and I'm wearing white here, it's not my white coat, but we know of the white coat effect, and it is amazing. And that's why, I tell my students, don't let them away. The side effect, the placebo effect is amazing. If you can do that as well on the top of your treatment, that's amazing. But you have to understand that part of what we do is just a pure main placebo effect. Patients will feel better if you care for them. A lot of my patients get no improvements at all in a lot of things, but they come feeling so much better, and they're so thankful because I care about them and I do everything that I can. And what we know, yes, you put a little splint in their mouth, they may be, having a little bit more of a plane, maybe to clench around and do little things. It is likely not the apneas. It's not the repositioning of the condyle. You haven't looked at everything else. And that's what we don't do in medicine. You don't come in and say, I have a problem with my knee, and you're doing CT scan of the knees and the right and the left and the shoulders and so on and so forth, because those are incidental findings that do not require treatment. So I, in my point of view, you have overtreated a child or a young adult, sorry to say, who actually doesn't need and may actually be in the need of an antidepressant, or maybe in the need of something else. We all click back and forth, and that's where the evidence have shown in TMJ field that it was overused, the treatment for clicks. Clicks are normal, they come and they go.
I agree with you, but I wasn't treating the click.
Right, I know, but you were afraid that the click was coming and doing something.
No, just someone
or
mentioned
maybe
to me,
doing whatever.
just why don't you just go protrusive and come back, see if there's a click, reline the appliance, see what happens.
Yeah,
so
it
I
added
had
you
him like
another
95% better.
Yeah,
and
because
I
you
was very
added two
surprised.
treatments. You added 2 times that he had to come and see you. You cared for him twice as much that you had before.
Okay,
Well,
Dr.
it's
Almeida.
you could just not argue, but you could have this discussion
Forever.
There would be no end.
Mm-hmm.
Right. Okay. Thank you, Paul. Dr.
Thank
Almeida,
you.
you've expressed the concept that you're outspoken and you have some strong feelings. Let me just ask you what you think about DICE, drug-induced sleep endoscopy, because Dr. Sharon Morong, who is a member and has presented on it, she's only one of 3 centers in Canada that do it.
Mhm.
Toronto, London, and I think Edmonton. Now that's very expensive and very invasive kind of procedure, and our patients have to go to a hospital. But Balance to get your thoughts about imaging. What do you think about direct vision with sleep endoscopy?
Okay, so I do like DICE in many ways. I think that there's a lot more evidence on DICE. I think DICE does get the closest to sleep and function that we can to look at the airway. We have seen, for example, there are a lot of therapies for pediatric sleep medicine that you have to have a DICE prior to be approved, you know, some higher level surgeries. So you have to have that. And it is very precise because you can visualize properly the soft tissue and how they act and their function as well during sleep. So, or closer to sleep. So I think those things are highly important, is highly respected, and the outcomes have been great. I think in oral appliance field, unfortunately, I feel that the cost of going through the DICE is almost the cost of the treatment. And the patient may as well has the treatment to be able to, let's say, then have it on the weekends or add it on to the CPAP beyond putting the patient through that costly treatment, because oral appliance would be likely not invasive. If it doesn't work, you take it out and that's fine, which is different than surgeries. So for surgery and for example, as we know, for example, for the genioglossus activation or the hypoglossal nerve stimulation, it is a requirement to do the DICE prior, and I fully agree. For a lot of surgeries in the pediatric field, it is a requirement, and I fully agree. For oral appliance, the predictors were not as strong for me, in my point of view here, they were not as strong per cost, per dollar value, if you want to say. Okay, so I think that's the only thing. If it was less costly, by all means, but now bringing the discussion to Canada, I think it is very hard for us to find the space and a hospital to do it, where I would say it's likely not going to be standard of care for patients on oral appliances in the adult population, not at this point.
Thank you. Mark, what's your thought? Is it available at all in Montreal? Have you had experience with it? DICE, I'm talking about.
ENTs don't do anything without a billing code, and I've never seen an ENT doing it, so I don't think there's a billing code. That's where I think it is in Quebec in general. It may be done in pediatrics, for example, because they have a completely different set of codes. Nelly, have you seen any ENTs do it in Sainte-Justine? I've never heard of it.
Oh, but I could ask to see if they do it and what their experience, and have them come and speak to it, but not on the top of my head. It's not standard procedure, but it might, maybe I should ask.
So I want to thank you two ladies tonight, and thank Dr. Baltzan for encouraging you to come. You've opened the door for a whole bunch of ideas that we will explore with you over the summer, because as I said, I want to bring this to a more general dental population because we should all know it. Thanks so much. Good night, folks.
Good night. Pleasure being here with you all.
Thank you so
Bye.
much.